Hello, everyone, and welcome to today's AC Forum webinar. We are thrilled to discuss a very important topic near and dear to my heart, subclinical atrial fibrillation, connecting evidence to practice. As we discuss, as a reminder, we won't be using the chat box. You use the Q&A box if you want to submit any questions as we go along. We also have some pre-submitted questions. And we will have plenty of time to chat with our esteemed panel. Next slide, please. And speaking of our esteemed panel, I am here with my co-moderator, Naomi Yates. And we are just thrilled to have the people to be discussing this topic. We have Jeff Healey, who was the lead author on the Artesia trial, which really kind of has started this discussion over the last little bit, as well as Paulus Kirchhof, who was the lead on the AFNet-NOAA trial. There have been also subgroup analyses of these trials. There's been a meta-analysis of these trials as well. We were expected to have Renato Lopes, and I apologize. He had to cancel very last minute for an urgent thing that came up, and so he's not going to be able to be on. He was involved in AFNet-NOAA, as well as the meta-analyses and some subgroup work that has happened beyond that, some post-hoc analyses. So we just have the people to speak to about this. So just in brief introduction, Naomi Yates, my co-moderator, is the manager in clinical pharmacy services, the manager of the clinical pharmacy services for outpatient pharmacy and the Anticoag service at Kaiser Permanente in Georgia. We have Jeff Healey, who's a cardiologist, electrophysiologist, and professor of medicine at McMaster University. We have Paul Kirchhof, who is the director of the Department of Cardiology, University Heart and Vascular Center in Hamburg, at the University Medicine Center in Hamburg, Eppendorf. So we are thrilled to have this discussion. I'm going to kick it over to Jeff Healey, and away we go.
Yeah, thanks, Art, for the kind introduction. I'm going to be brief because already I see that we have a fair number of questions. Please encourage people to send in questions. You know, we have a lot of people to discuss this topic, and I think that's really where the fun is. But I'll give you an update of where we are with clinical trial data. The two trials, NOAA, AFNet, and Artesia, have been out in print now for over a year, but people have been working hard on sub-analyses to describe and to better understand these results, which are requiring some better understanding. So what are we talking about? We're talking about device-detected subclinical atrial fibrillation. And right off the bat, you know, I think we have gravitated more to this device-detected term, you know, because subclinical has this connotation that you should just forget it and ignore it. I'd like to show you that I think in some cases we can put it off, but in many cases we have to contemplate what to do. But this is largely asymptomatic atrial fibrillation lasting hours or minutes only and detected with long-term continuous monitoring. So we're talking implanted pacemaker, implanted defibrillator, or implanted cardiac monitor. And here's just a good example of a strip that was published a few years ago. Now, we're going to talk about implanted devices. The reality is this is an important topic to understand because more and more consumer-facing devices, phones, rings, watches are becoming increasingly used by people in the community. And actually, we can argue over this in the discussion, but I think fast forward 5 to 10 years, and a sizable number of our patients with atrial fibrillation will actually be detected through this means. And so really, it's imperative for us to understand you know, what to do with this type of atrial fibrillation that doesn't present in the classic clinical way. So what does it mean? Device-detected atrial fibrillation, as I said, it's short-lasting. You might find it in up to 1/3 of individuals over 65 with typical cardiovascular conditions, as well as those requiring a pacemaker or ICD. We do know that it's associated with a risk of stroke. This is the TRENDS and ASSERT trial from 20 years ago. It clearly increases the risk of stroke, but it is a lower risk than we see with the traditional ECG-detected atrial fibrillation, and that's why these two studies were needed. We know that anticoagulants prevent stroke due to clinical atrial fibrillation, but given the lower rate of stroke here with the device-detected variety, is this still applicable? Is there still risk-benefit to be had in this population? So here's the risk. These are our data from CERT in 2012. You can see there in gold, it's a 2.5 times increase in the relative risk of stroke if you have device-detected atrial fibrillation. But look at this number and actually file it away for memory. It's about 1.7% per year, all comers, if you don't treat it. So that's much lower than we would have expected based on clinical atrial fibrillation, but it's still significant and it's still increased. Now, what do we do about it? These are the pre-trial, 2020, so before trends or before NOAA or Artesia were published, and we get this kind of box here on the right, where we see rates of about 1.5 or greater percent there in the red. Back in 2020, the suggestion was maybe we should treat those. Maybe we should ignore the boxes in the green, those with rates lower than 1%. And then there's the in-between bit where it's even less clear what to do about it. But this, was the framework. It was based both on the CHADS-VAS score you see there, but also the duration and the burden of atrial fibrillation, which we felt could be important. So this is where we're starting to, if you want to look at this kind of issue in a Bayesian sort of way. I'll start with Artesia. It's a double-blind, double-dummy trial comparing apixaban to aspirin in an at-risk population with device-detected atrial fibrillation lasting 6 minutes to 24 hours. And you can see there the CHADS-VAS factors on the left, which were required to participate. The outcome was the typical outcome that we used in our AF anticoagulation trials like SPAF or Averroes, and this is stroke or systemic embolism, looking at a safety outcome of major bleeding. And so, that's the nutshell of Artesia. You will see that there's slight differences with NOAA. The outcome is a little broader to include things like cardiovascular death. And here, in NOAA, the comparator is either aspirin or placebo. That speaks a little bit to the differences. Remembering 15 years ago, we used a lot more aspirin in North America. The Europeans were earlier to move away from aspirin for atrial fibrillation. And so these are why you have these design differences, which actually become interesting when we do the analyses. So that's our design, pretty simple, 4,012 patients. And here's the top line results. So you can see in red, the aspirin-treated patients, stroke rate of about 1.24% per year. So it's in that between 1 and 2% box. It's statistically probably not far off 1.69%. Those are pretty small numbers to begin with, but it's there. And it does go down by a third with apixaban to 0.78%. So that's a highly significant result. You can see the confidence interval there is well below 1 at 0.88. So, there's clear evidence here in Artesia that treating with an anticoagulant compared to aspirin prevents stroke and embolism. That's quite clear. What's also clear is that the numbers are pretty small. And so we want to place this in the context of, what were the strokes about and what were the bleeds about. So looking at stroke, you can see here, again, in all the components, ischemic stroke, total stroke, the treatment effect is the same. And if anything, hemorrhagic stroke is also lower with apixaban, although we're talking 10 versus 13 strokes. So not really significant, but clearly not going the other way. The second thing is, and we tease this out further in subsequent analyses, you see that the types of strokes we're having here, about 40% of the strokes are having a modified Rankin score of 3 to 6. So these are bad strokes, right? Strokes with residual disability and death. And you can see that they're about 40% of the strokes that happen in the trial. That was a little surprising. We thought they would largely be smaller strokes. And you can see for those bad strokes, the reduction is about 50%. Again, that's not so different than 32% for the smaller strokes, but again, it is something we can drill into in the subsequent slides. Cardiovascular death is no different. Major bleeding is increased. This is the intention to treat, so the numbers will be even more pronounced on the on-treatment analysis, but about a 36% increase in major bleeding. However, the bleeding here in large measure was category 1 and 2 major bleeds, so bleeds that respond to conservative measures or supportive care. Fatal bleeds were no different. Intracranial bleeds were no different. And there was no difference in bleeds that required acute measures such as surgery or procedures to prevent death. So Much of this was conservatively managed bleeding or supportive care, such as crystalloid or blood transfusion. And so how do you balance that? And this is going to be a long-standing topic. I'll put some just very interesting guideposts out here. Stu Connolly, who died this year, was one of the greats in the AFib research. He looked at how bleeds and strokes compared in terms of their downstream impact on mortality. And you can see that major bleeds had about 2/3 of the subsequent risk of death as a stroke. If you want to look at utility scores, this is how well people do. So major bleeds, they tend to have a moderate effect on impairing people's quality of life that tends to be short lasting, whereas, sort of similar to a minor stroke, if you will. But when we're talking about those 40% strokes that are major, you can see here 0.11 means that they eliminate about 89% of patients' perceived quality of life. And so on net, if you look at the patient preference surveys, as physicians, we tend to treat them the same or even try to avoid bleeds more than strokes. If you ask the patients, they are more inclined to avoid strokes at the expense of, in this case, up to 4 major bleeds to prevent 1 stroke. So park that again as we, value these various outcomes. Now, the NOAA AFNet 6 we showed here, again, it's a broader definition. So yes, stroke and embolism are in there, but so are cardiovascular death, MI, pulmonary embolism as well. No significant difference over the course of follow-up here, and you can see the curves there. Now, we did have a very nice collaboration between the groups, Dr. Kirchhof and I, as well as our collaborators, Nina Becker and Bill McIntyre led this analysis. This is a summary level meta-analysis where we just take the published results of the trials and we put them into a program to combine them. And I'll walk you through here for the simplest outcome, which is ischemic stroke. And you can see here NOAA's trending non-significantly to 19% fewer ischemic strokes. Artesia is significant with 37%. And you can see there the pooled result is a 32% reduction in ischemic stroke. More importantly, this I-squared value here, as well as your visual look at these curves, suggest that these intervals highly overlap. So the conclusion here is on ischemic stroke, they're saying the same thing. The trials, you can see about 70% of the outcomes pooled come from Artesia, about 30% of them come from NOAA, but the overall effect on stroke is consistent, very consistent against the trials, about a 1/3 reduction. For the NOAA composite here, which includes all of these things, you can see it's about a 15% reduction. It is barely significant. That's like a 0.04 something p-value, 0.03 rather. And again, you can see those confidence intervals highly overlap. So the first thing we challenged with in these trials was that the event rates were small. So even trials of many thousands of patients had relatively modest statistical power. So this is why these confidence intervals cross. But if you add these all up, you can see that the confidence intervals clearly favor some degree of benefit, although it's a small benefit in relative terms, 15%. And when you're talking about, stroke rates of here 3% or 2%, these are small absolute benefits. So that's the first thing on stroke, as well as the NOAA composite of events. Now, those are fairly consistent between the trials. Where we get into some differences here are on bleeding. And this is by design, right? The trials are different. You can see here the Artesia effect is more modest. There's not that much different in this analysis using the methodology here. It's borderline significant, more bleeds with the DOAC. However, with NOAA, it's quite a bit more. And what's the difference here? Well, there was a large number of patients, around half the patients in NOAA, that had placebo as their control. And obviously, aspirin does cause bleeds. So when you're comparing DOAC versus placebo, there's going to be a greater effect. And you see this I-squared value, which was 0 for the first 2 panels, now 61% saying, yeah, these trials are different, but it's a difference by design. So more major bleeding. And again, this will come up when we look at the group of patients in NOAA who are on aspirin by indication for like coronary disease or vascular disease, as well as the Artesia patients similarly. So compared to no therapy, yeah, there's quite a bit more bleeding, 2.11 relative risk. Compared to aspirin, much more muted but in terms of fatal bleeding, there's nothing going on in either trial. So again, the bleeds tend to be category 1 and 2 responding to simple measures. So that's where we are with the main effects of the trial. Major bleeding, stroke and embolism, the NOAA composite. What about subgroups? Now, we're going to start with subgroups here using CHA2DS2-VASc. And again, remember, these patients are about 10 years older than your typical AF patient. So the CHA2DS2-VASc scores are quite high. And this is a pre-specified look based on the CHA2DS2-VASc, whether it's equal to 4, greater than 4, or less than 4. And why do we start with that one? Because, well, that's how we manage atrial fibrillation, right? If patients are in atrial fibrillation all the time, but they don't have any CHA2DS2-VASc points, we don't anticoagulate them. And this is the accepted way we triage. You can argue whether it's CHA2DS2-VA or something else, but at the time this trial was completed, this is what was used and in the guidelines. Now, to the eye, you can see here for stroke or embolism, anything to the left means the apixaban is doing a better job. You can see here, it looks like these are relative risks here on this set of axes, looks like they're getting stronger, going from a 13% reduction for the low CHA2DS2-VASc to a 56% reduction with the CHA2DS2-VASc greater than 4. But this interaction p-value tells the story. Anything greater than 0.1 is really not significant. So although that looks favorable in terms of better stroke prevention, relatively speaking, it's really not of that much interest statistically. Similarly for bleeds, there's this softer trend, but again, no real interaction. But remember, the stroke prevention, we don't care as much about relative. What we care about is how many patients we treat and what's the absolute risk of stroke. And so when we do this here, we do get a significant P interaction. And you can see here the benefit, virtually no benefit to treating CHA2DS2-VASc less than 4. This is over 3.5 years, just to be clear, as indicated at the bottom. You get a bigger benefit at CHA2DS2-VASc equal to 4. And then when you get over 4, it's about a 4% absolute reduction over the life of the Artesia trial, with, again, nothing much shaking out in terms of the bleeding. So this is why the conclusion of Renato Lopes, who unfortunately couldn't join us today, his paper was the conclusion of this. And to keep it really simple, there's about 40% of people in this trial with a CHA2DS2-VASc less than 4. They derive virtually no benefit in terms of stroke prevention, but at an expense of 1 major bleed per every 78 people treated. So conclusion, do not treat them with an anticoagulant. On the other hand, there's a smaller percentage, about 30% of people with a high CHA2DS2-VASc score of greater than 4. They save about 4 strokes, so an NNT for 3.5 years of only 25 people, with an increase in stroke with an NNH, number needed to harm, of 59. So the conclusion here is, in most cases, probably treat. Here in the middle part, it's less obvious. It's about a third of cases, and the stroke rate is reduced. But I would argue here, again, I like to start with what I'm most confident with. CHA2DS2-VASc equal to 4. Again, I think you can funnel that down your shared decision-making model, which we'll talk more at the end. So high CHA2DS2-VASc greater than 4, that's one group where I think treatment can be and should be considered. I think the CHA2DS2-VASc less than 4 is a group where, for the most part, unless the patient has anything else special, I think we should confidently not treat them, although, again, continue to follow them, because somewhere around 8% of those patients each year will go on to clinically detected ECG-detected atrial fibrillation. So that's the first kind of cut of the data on CHA2DS2-VASc. And we'll move into the next cut of the data, which is, does the patient have a history of stroke or embolism? Okay, so this was just published in Lancet Neurology a few days ago. This is the group of patients here on the left where there was a history of stroke, or TIA in this case. And you can see at 3 years, their risk of stroke is about 10%. So about 3% a year. Stroke risk a little higher. So that's not 1.24% per year. This is about 3 times higher if you have a history of stroke or TIA. And treatment with apixaban here reduced that risk in absolute terms by 6%, giving you a number needed to treat to prevent a stroke or embolism of 16. So a very compelling case here with a 3-year stroke rate here around 10%. So that's a big number. In terms of those without, you can still see there's a borderline significant reduction in stroke through treatment with apixaban. It's a 31%. The P is 0.04 something. And you can see here in absolute terms, right, that stroke risk is less than 5% at 3 years. So again, that's closer to your 1.1% stroke rate that you would expect. The interaction p-value here is significant, meaning that there's significantly more benefit in the prior stroke TIA patients here than there is in the other patients. But we don't, we still see an effect, although the absolute reduction here is a fraction. It's 1/6 of what we see in the prior stroke group. Okay, and again, just the last point, we talked about these bad disabling strokes here, ranking 3 to 6. Here we see a 74% reduction in those bad strokes, going from 6.9% down to 1.7. So the second group of interest for me is our patients with a history of stroke, TIA, or embolism, where I think there is more solid evidence where treatment matters. Again, Noah has published a paper on this. Paulus can speak to it in the discussion period. You can see here when we plot the two on a meta-analysis curve, you see that same story, right? The curves highly overlap. There's no difference, really, statistically speaking, in the outcome of these two trials. The net is about a 60% reduction in stroke and embolism with treatment. That I-squared value, again, that measure of heterogeneity is 0. And you can see here just the number of strokes, right? 4 strokes, 7 strokes, 7, 18. So, we're talking 36 strokes to make the whole story. That is a limitation. The fortunate event is that the rate of stroke and the risk reduction in stroke is high enough that you can, get a highly significant, or 0.02, so a significant result with even so little strokes. But, knowing the effort that went into doing these two trials, a couple of decades worth of work total, that is a, to come out with this, it is fortunate because, it is a relatively small number of strokes, but that's the best available evidence we have and probably will ever have. The last group, and this was the last subgroup of interest, so beyond high CHA2DS2-VASc, beyond history of stroke or TIA, is this analysis that the Noah group brought forward, which is looking at patients who had an indication for aspirin already. So why is that important? Well, we had differences between the trials and how we were designed. Artesia only aspirin control. Noah had a flexible control, which could be placebo. But when you think about this objectively, right? So if you have a history of stroke, or you have a MI or something like this, you're going to be treated with aspirin, and that is a fact, right? Like you're not going to have someone who just had a stroke yesterday with carotid disease. You're not going to treat them with placebo, right? So that is, for those patients, I think most people can agree that aspirin is the background therapy. Person with a coronary stent implanted last month, you're not going to treat them with placebo. They're going to be on antiplatelet therapy. So, and why that is important is twofold. One, if we look at stroke and embolism, you can see here, the event rates all of a sudden get higher, right? So the control rate pooled here for those with a history of vascular disease is almost 2% per year, okay? If you look at those without vascular disease, it's 0.8%. So, we used to fall into this trap and say, okay, well, atrial fibrillation patients with atrial fibrillation have different types of strokes. But here, we're actually saying that the vascular disease is important in terms of driving the risk of stroke, but also it appears to have a modest effect in driving the effective treatment. So these patients, although the interaction here is not so profound, but it's 0.11, so it's close, suggests that the patients with prior vascular disease have a tendency towards better benefit. But I wouldn't hang your hat on that. That's not the real story, but it's a trend. It's interesting. I wouldn't take that one to the bank. But what's clear is this, okay? They're already committed to aspirin. Aspirin, so the jump up, as we talked about before, from aspirin to DOAC is a lot less in terms of major bleeding risk than it is going from placebo to anticoagulants. So they're already committed to some antithrombotic, typically aspirin. And so for them, although the incremental benefit of an anticoagulant, like I said, is probable but not definitive, the cost of doing so is relatively modest, right? And we've got lots of great data now Renato Lopes and others with clinical trials such as Augustus showing that, in these patients with coronary disease, antithrombotics can include anticoagulants with good effect. So it's really less of a safety concern here compared to down here with the patients with no vascular disease. You can see there's much greater effect, especially in NOAA, where the comparator here was largely placebo. You can see that's where the big difference, a 3.4-fold increase in bleeding, occurs. So those are the the subgroups. CHADS vascular greater than 4, history of stroke, TIA, or embolism, and possibly those patients already committed to an antiplatelet agent because of coronary, peripheral vascular, or cerebrovascular disease. Lastly, what didn't predict, and this was a little bit of a surprise to us, was the amount of subclinical device-detected atrial fibrillation. And, I don't think this means that burden's not important. Burden is important. I think just what we're talking about in these trials is a fairly narrow slice of burden in the neighborhood of 0.01 to 0.1 or maybe 0.5% burden. And so across that range, which is pretty tight, what we couldn't find was any difference in the risk of stroke or embolism. And I won't show the slides from Artesia, but we didn't find any difference in the benefit or lack of benefit of therapy based on burden. So, a 1-hour episode and a 7-hour episode had roughly the same stroke risk and roughly the same chance of benefiting from apixaban. The NOAA data are also fairly flat when it comes to burden within this fairly narrow range of patients that we studied in our 2 trials. So, the clinical factors, any signal here we have for, teasing out who to treat comes largely from the clinical factors and not from this narrow band of burden. And I think, that is important. And, I place this in the context is we're not dealing with trials that were negative and we're trying to, torture our data to find a group that might benefit here or there. Especially in the case of Artesia, we have an overall positive trial, but, have to accept that the absolute event rates are lower, although more or less what we predicted based on a certain trends. And we have to define patients, given the risk of bleeding, where the absolute benefit warrants therapy. So it's not a post hoc analysis of a negative trial, but rather a post hoc analysis of a positive trial looking at defining groups that benefit. So the American guidelines here, obviously written before these trials came to light. Actually, the top line of NOAA was probably known, but as we all know, that right guidelines, these guidelines go into various committees for quite some time before they ultimately come out in print. You can see here a big gaping hole in this device-detected AFib piece, which Artesia NOAA will provide some evidence, so I guess that's fair. And again, we've kind of shifted, and we can talk about why. 15 years ago, 1% was kind of our line in the sand to treat. Now the guidelines here, we said below 1% we don't treat. That hasn't changed, but we're a little more circumspect with this 1 to 2% range, and over 2 is where we draw the line to treat. And that makes sense, right? We're much bigger on treating risk factors, hypertension, heart failure. That probably takes away some of the risk. We're much better at rhythm control, including catheter-based rhythm control, and that may take away some of the risk as well. But if you're looking at prior stroke and TIA, that was a 3% per year. If you're looking at CHADS vascular greater than 4, that's a 2.25% per year. And if you're looking at the prior vascular disease or indication for aspirin, that's about there. It's about 1.9% per year. So that's sort of how we place this in the context of these American guidelines, or how I do anyway. So I would conclude by saying, the clinical trials, and I would argue both trials, show that anticoagulation does reduce stroke and device-detected atrial fibrillation at the expense of increasing bleeding, that the stroke rates are lower than clinical atrial fibrillation, making the bleeding conversation much more relevant. But I think it is a consistent effect. Who are the subgroups where we get to this 2% range, prior stroke, CHADS vascular more than 4, and close with this history of cardiovascular disease? The burden really doesn't help us, but again, keep in mind, it's very different when we're going from 0.1 to 0.01% burden, not the same as going from, say, 0.1 to 10% burden. I think there's pretty good evidence that burden does matter for absolute stroke rate prediction. I think you can with these data, say that there's about 30 to 40% of these patients that could be treated with an anticoagulant, and there's 40% of patients right out of the bat that you shouldn't treat. And I think the clinical risk factors help us here. But whether you're treating or you're not treating with an anticoagulant, remember to follow patients along. They will go on to progress at a rate of about 8% a year, more to come on that in future talks. But the issue here is it doesn't matter whether they're on an anticoagulant or not on an anticoagulant, you still have to monitor for progression, because progression to longer lasting atrial fibrillation, as Paulus and others will tell you, the big outcome you're going to get into trouble with is actually heart failure hospitalization or heart failure death. So, we've really done a good job of driving down stroke risk in patients with atrial fibrillation. There's still a few places to push on it, but we've done a really great job over the last quarter century on this care. Where we need to focus some attention here is heart failure. Anticoagulants are not going to get us there. Rhythm control and risk factor management may get us there. But I think for those reasons, we do have to keep following the patients. So I'm going to stop my share, hand it back to Art to launch into the question period.
Thank you so much. Great presentation. Really excellent information. For those of you that have followed this, there's been a lot to say about subclinical atrial fibrillation. In fact, before jumping on this call, I just did a quick PubMed search using Artesia and NOAA-AFNet as the search criteria, and there were 44 publications with Artesia in the title or abstract and 23 for NOAA-AFNet. So people have a lot to say about this. They even published a letter that I wrote on our Artesia when it first came out. So just excellent information. We'll go ahead and bring the rest of our panelists to screen if we haven't already. Yeah, thank you. And I wanted to give, I think it would have been more entertaining if the two studies really didn't correlate, so that we could throw Jeff and Paulus into a cage and let them fight this out. But I do want to give Paulus the opportunity to chime in and give us any additional feedback or any words of wisdom in response to the presentation we just saw.
Yeah, well, thank you. I think this, well, first of all, Jeff gave a brilliant presentation of what is a fast-moving field. I think it's fair to say that when we started NOAA, and I think when Jeff and his team started Artesia, we felt that it's likely that the anticoagulant is going to win, quote unquote. And the most consistent finding for me is as Jeff said, that the stroke rate in device-detected atrial fibrillation, as we detected now, is about half of what we expected. And we expected a stroke rate of around 2% per year. You can read that in our design paper, and I think the same was true for Artesia. And there was a stroke rate of 1% per year. And I think one of the things that actually changed even between ASSERT and the start of NOAA and Artesia is that there are more ECGs being done. So people are diagnosed with ECG-documented atrial fibrillation much more commonly. And the second thing that I think is worth mentioning is we stopped NOAA AFNet 6 early based on a recommendation from the Data Safety Monitoring Board because of expected safety outcomes, the increase in bleeding that you would expect with an anticoagulant, and the trend towards futility. And that actually includes a numerical signal for not less mortality with anticoagulant, which is what we would expect, but if anything, a bit more than that. And that is also a consistent finding across the two trials when you look at the meta-analysis. So I think it's, as Jeff said, there is an effect that you can see. There is a price to be paid for that, and there's probably a group of people that benefit from anticoagulation, and there's a group of people that don't. And at least in our practice, even those where we think they benefit from anticoagulation, it's probably a process of shared decision-making rather than, as we are used to in ECG documented AF, telling them, well, look, you actually need an anticoagulant, and I will tell you why.
Excellent. Yeah, thanks for those points. I did have a question. I want to go back to Jeff for a moment. So there, again, you pointed out the differences in the trials that are Artesia compared to aspirin. When I first saw the trial, I thought, well, that's odd. We kind of finally know that aspirin, we finally, in the US guidelines, we finally, removed aspirin as having any role in stroke prevention and atrial fibrillation, which has been a long time coming. But I understand kind of why it was done based on when the trial was done. I think you would have probably had recruitment issues, honestly, for folks not willing to have folks on nothing. But when you look at specifically those patients that were on aspirin, or the fact that you compared to aspirin, and we think about the Chad's VASC of 4 kind of cut point that we chatted about, should we take away from that, well, since Artesia compared to aspirin, that group should be on aspirin, or can we jump to no, aspirin has nothing to do with it? Treat or don't treat. Use Chad's VASC 4 as a cut point.
Yeah, it's an interesting question, and trials take 10 to 12 years. Any good trial of this size takes 10 to 12 years to come to fruition, and the world changes substantially, right? Over 10 to 12 years. We didn't have smartphones, I think, when we started our search, so a lot has changed. It highlights the differences between the continents. We had many ethics boards that would not allow us to use placebo in North America back in the day, because we had this habit of treating low-risk atrial fibrillation with aspirin, right? And it was just, whereas Europe was a little bit quicker off the blocks on that one and deviating from aspirin. So that's important. Where I think the coalition is here, we're fussing over the very, very specifics. But if you look at the broad strokes, again, I've highlighted 3 subgroups: prior stroke embolism, TIA, prior cerebrovascular, peripheral vascular, cardiovascular disease, and high Chad's VASC. The first 2, okay, so a patient had a TIA or a stroke. Who's not treating with any antithrombotic here? Assuming it's not a bleed, right? Everyone's going to get antithrombotics. Patient had an MI, a stent, a CABG. Who's not using antiplatelet agents here? Nobody. So for those first 2 groups, I would argue that the vast majority, there's going to be some exceptions, but the vast majority of patients are already committed on aspirin. So that's the relevant comparator. It gets a little less dogmatic in the Chad's VASC greater than 4, because what is that? Is that a stroke, coronary disease, and female sex? Or is that, an 80-year-old man with controlled hypertension and treated heart failure? And I think that's where you get into the nuance, is the first question. But I think for most of those patients where we're saying you might strongly consider to treat, not making it a class 1, but just saying, yeah, I think these patients really should be treated. I think most of those patients are going to be on an anticoagulant, but the devil's in the details. And when we say use shared decision-making, it really has to be informed shared decision-making. So, there are a few large surveys coming up, patient preference, where we're, doing very formal assessment of patients' preferences. You can't walk into a shared decision-making conversation and said, well, it's pretty low risk and anticoagulants suck, so do you want to take them? That's not really what we have in mind, right? Like it's really kind of laying it out, and it does take some time to kind of drill into it. But I think the short answer to your question is many of the subgroups where we think the benefit lies in terms of stroke prevention, where the risk lies in terms of stroke, these are overwhelmingly, probably 80–90% of those patients are indicated for aspirin anyway. And to the point of the NOAA paper, there you're paying less of a price on bleeding, because aspirin causes bleeding, and it is a higher bleeding situation than being on no therapy.
And then, so to your point, those patients who are already committed to antithrombotic therapy, it's a smaller jump to go ahead and assume that they were going to gain more benefit than harm from jumping from the anticoagulant.
It's less of an ante for them to get in on the game. And again, I think if we're going to say treat over 2% per year stroke risk and consider it in the 1 to 2 band, that kind of all fits consistently with those broad strokes. The one thing I want to pick up on Paulus, because I think it's important. We talk about Chad's VASC. This scale is changing, right? We are now looking for better ways to triage this risk. I saw a lady in my clinic like 2 hours ago. She has a Chad's VASC of 3 because she's a 60-something-year-old woman with hypertension. Her blood pressure is pristine. It's like 115/70. It's been that way for 3 years. Is that the same? When we studied this in Averroes and active among non-anticoagulated patients, history of hypertension doesn't predict stroke at all. Zero prediction. What predicts is systolic blood pressure. And so I think how we address the risk factors, and this comes out in the European guidelines and the American guidelines, is an important pillar of ABCD care, right? Is heart failure in 1985 with a big dilated ventricle full of thrombus, is that the same risk for an AFib patient as someone with an EF of 42% on 4-pillar anti-heart failure therapy? I'm not sure we know the answer to that yet. But again, when we run heart failure in our aspirin-treated cohorts from Active and Averroes, it doesn't predict. It doesn't come out as an independent predictor there. So I think the story on the risk factors are tough, right? You gotta deliver the therapy. But I think that's the other part of the equation, why the rates of stroke we see in these trials is lower than the trials upon which they were based back 15 years ago. Is I think for the types of people we get into our trials, typically from our centers with great doctors and nurses, we do a much better job of treating the everything else. Paulus, what do you think?
Well, I think that is definitely one of the areas where things have moved. And I actually find this dichotomy, does the patient actually need aspirin or not, quite helpful. And I also agree with what Jeff said, the needle is moving. And when I talk to my colleagues who are interventional cardiologists, even the ones with stable coronary artery disease get less and less exposure to dual antiplatelet therapy and even to long-term aspirin. So I think that is one of the aspects. The other aspects when we talk about broad strokes, a few years ago, we published a study, acronym EAST AFNet4, that actually found that early rhythm control, where you reduce the AF burden by some degree, but you don't eliminate AF, reduce the rate of stroke by 30%, 60 or versus 40 strokes. There is, I think, one trial that we'll report later this year, where in patients with a CHA2DS2-VASc score of 2 or more, withdrawal of anticoagulation after so-called successful AF ablation, where you still have a few episodes of short AF probably, is compared to continuation of anticoagulation. So I think this whole issue of how much atrial fibrillation actually increases the risk of stroke is resurfacing. And one of the sub-analyses that we only could do in NOAA is we also looked at the patients who had very long episodes. So we had episodes of device-detected AF of more than 24 hours. And the stroke rate wasn't higher than in those with the shorter episodes. And now our current interpretation of the data, but we don't have the evidence for that yet, is that there's probably an exponential relation. You see,
yeah, I agree. It's probably logarithmic, right?
Yeah, it's a logarithmic.
100%, 10%, 1%, 0.1%.
Exactly. You get a tenfold increase in AF burden, then you get a measurable increase in stroke risk. So, and in a way that makes life easier. In our clinics, we see patients who come in with their smart watches and they have an hour of AF. And it's an AF when you look at it, but it's 1 hour per 6 months of monitoring. And unless they may have had a prior stroke, these are probably not patients whose AF-related stroke risk is so high that it warrants the risk of anticoagulation, which is largely independent of AF. When you take an anticoagulant, you double your risk of bleeding compared to no antithrombotic therapy, whether you have AF or not.
Yeah, and so to your point, Jeff, about the one of the things that came to mind when you mentioned kind of basically not all patients are the same, right? We all like the idea of cookie cutter CHA2DS2-VASc, but not all patients are the same. I would just point out, I actually led the AC Forum webinar on the new North American guidelines for atrial fibrillation. One of the key changes in there that I would again point out to our audience is that prior versions of the guidelines really spoke to CHA2DS2-VASc score of XYZ, do this. What the actual change, and it was always the intent, but what they actually did in the language is to say, it's about estimated stroke risk. CHA2DS2-VASc is a way of estimating stroke risk. There are others. And so to your point, you have to wonder if, in a patient like the one you described, there's not a better tool that could be used in that patient. So I would just point that out to our audience as well, just a reminder of that. Naomi, you have a question for us from the audience, maybe?
Yes, we have a couple of questions in the Q&A, and I see Jeff is trying to handle them. There's one that I was hoping that we could answer live, and that is what constitutes atrial high rate episodes, and what is the concern there? And I know that we're mostly talking about AFib, aflutter, atrial tachycardia, but what about PACs, ectopic atrial rhythms, and MATs?
This is a great question, and so when we designed NOAA, we talked about atrial high rate episodes because we wanted to make it clear that this is not ECG documented AF. I think the first thing to say is, and that's critical, and it's true for both studies and for the observational data, only patients who had an episode duration of more than 5 or 6 minutes were included. The reason for that is not anything biological. It's not the biology or the pathophysiology. It's the mere fact that shorter episodes cannot be discerned from artifacts. So if you have someone who comes in with a pacemaker and says, oh, I've got an episode of AF of 1 minute or PACs, it's very hard to tell that apart from artifacts. Now, knowing what we know now about AF burden, it's probably also something that is a bit less relevant. So that's the first thing to actually recognize. All the patients that went in there had an episode duration of at least 6 minutes. And we then analyzed, so we had a core lab run by Uli Schotten and his team from the University of Maastricht, and they looked at all the pacemaker and device reports of all the patients at baseline. 97% of the episodes were atrial fibrillation. So these discussions about could it be something else, atrial tachycardia, atrial flutter, is it ectopic, is it reentrant, can you ablate it? This may occasionally be the case, but you can safely ignore it for 97 to 98% of the patients because these are rarities.
Yeah, I totally agree with that. I mean, pacemaker, we're staring at a right atrial electrogram, right? And anybody that spends time in the EP lab knows that that can look spot on regular, even in the face of clear-cut ECG AFib. So it's a tough call. We looked at it in ASSERT, if those electrograms were regular, totally chaotic, or something in between. ASSERT, obviously, nobody got anticoagulants, and the stroke rate was exactly the same for all three. So there was no risk. It's impossible to tell them apart. And I agree wholeheartedly with Paulus's comment that short episodes are a bit of a uncertainty what you're actually dealing with. So if we're dealing with seconds of device-detected atrial fibrillation, we tend to ignore it because in many cases it's not real.
Along those same lines, kind of, we had a good pre-submitted question that was kind of, I would say, subclinical AFib adjacent, and that is the topic of transient provoked AFib, and there's really kind of two categories in my mind: surgically provoked, and we're usually talking about CT surgery, and non-surgically provoked by, say, medical illness. I would love to hear. I know we have I think it's the Aspire AF trial. That's coming to hopefully give us more insight into surgically provoked. But I would love to hear your opinions on, what to do with that, how to manage it, and when and if oral anticoagulant therapy is justified.
Yeah, so it's an interesting question. And you're right, it is indeed related because you can think of it as kind of like bycatch. Like the pacemaker detected atrial fibrillation, we're not looking for AFib, but we just happen to find it because we're monitoring inadvertently with a pacemaker. Surgical AFib and in-hospital medical illness AFib is the same thing, right? We hook patients up to a monitor for a week and, we're looking for asystoles and VTACs and stuff like that, but we're going to find it. So the question is, you're not looking for it. You find it with intensive monitoring. If the patient were not in hospital with pneumonia or with a hip fracture, but was at home and we just sent them a patch for the same duration of the time, would you be finding it? So is it triggered by the surgical or medical stressor, or is it just a function of taking an older person and sticking a monitor on them? Because we've done those studies. And if you monitor an old person for a year, you're going to find AFib in 20 or 30% of people. So that's the question. There's been many studies. Aspire, you mentioned, is an anticoagulation study that's ongoing. Our colleague Bill McIntyre has worked with both groups on this, published a series of trials called AFOTS, where they looked after the fact in patients who had medical or surgical illness diagnosed atrial fibrillation. We also did an interesting study, Bill led this, as part of a CERT, where we're looking at pacemaker patients who came in with a hip fracture or pulmonary embolism. It was interesting. Some of those illnesses, you did see a spike up in the rate of atrial arrhythmias. What were they? Things like MI, pulmonary embolism, obviously cardiac and thoracic surgery, they bumped up. Why? Because there's probably a direct insult there that's causing the inflammation or the triggers for atrial fibrillation. Whereas other things like, just general sepsis or a hip fracture, it was pretty flat. You saw some AFib in the 30 days after the procedure, but it wasn't, if you added up those thousands of patients, there wasn't really anything more than just the background noise. And so it's a mixed bag. So, my own approach to that is, you look at the patient from 10,000 feet. Okay, is this a patient with multiple AF risk factors who's 95 years old with a left atrium that's this big? Then you might assume, hey, that, you got to think twice before saying that's just because they came in with a UTI. Like, that's probably, you're targeting someone there that's probably got a risk of AFib all of the time. Versus, the young person that comes in with a benign pulmonary tumor that requires resection of part of their pericardium, that person may very well just have a perioperative AFib, and that's the end of it. But that's my own approach. So higher pretest likelihood, it's all Bayesian, the more kind of I pursue post-op, but that is my personal approach.
And I think the one important element in this consideration is, again, the atrial fibrillation burden. If you come to the hospital, you have one short episode of self-terminating atrial fibrillation and it's over after a few hours. That's probably a different animal as to I get atrial fibrillation, I'm discharged on atrial fibrillation, I still have atrial fibrillation 2 weeks later. Most of the transient atrial fibrillation diagnosis, I actually think we will move away from this binary diagnosis of I have AFib or I don't have AFib. It's still very useful in patients who have atrial fibrillation on a single short ECG. So there is no reason to be concerned that anticoagulation is not a good thing in most people who have ECG documented atrial fibrillation. But as soon as you move into longer monitoring periods, whether you are in a hospital, whether you have a smartwatch, whether you wear a patch, you actually pick up people who have very short, very low AF burdens. And I think there we'll probably have to learn a bit more, but I would guess that there is an area where we probably have to quantify the AF burden and integrate that in our decisions on anticoagulation and eventually also on rhythm control therapy. When you have a very high AF burden, actually, in addition to anticoagulation, antiarrhythmic drugs or even AF ablation may be a reasonable thing to reduce strokes.
Yeah, I mean, I'll be bold and say that in wealthy countries, and I think US, Canada, and Germany are still wealthy countries, I would propose in the next 5 to 10 years, the majority of AFib we're going to see is going to be picked up by monitor. It's just so pervasive, watches, rings, everything. You can already see it in my clinic, that people coming in with consumer-facing diagnoses.
Yeah. There are already more smartphones than people on this earth. And certainly...
Yeah, Paulus has his burner phone if you need to get him after the meeting.
Naomi, we're running out of time. I could talk about this stuff all day. Do you have maybe one more quick question we can hit with a 2 or 3 minute answer?
Yeah, one quick question about the differences in these trials, Artesia and NOAA AFNet. These were different medications. So do we attribute that to the differences that we see in bleeding? And then also in Artesia, it was noted, one of the questions that was submitted is that patients were able to take open label aspirin on top of the study medication. So, is that possible that could have contributed as well to the differences in bleeding that we're seeing with these two trials?
You want to start?
Yeah, I think the short answer on the type of DOAC is there is no difference. And I think Jeff has shown the meta-analyses. And when you compare apples with apples, so aspirin with the DOAC, both the treatment effect in terms of efficacy and the safety is the same. I think there is a major design difference, as Jeff pointed out, in that in NOAA, only 55% of the patients, a bit over half, got aspirin as the comparator, and the other did not get antithrombotic therapy. And I do think, and we discussed this here, we are moving away from aspirin for primary prevention of thromboembolic events in a general statement. And I think that the addition of open label aspirin is a small contributor, but Jeff can speak to that much better because that didn't happen in NOAA.
Yeah, sure. I mean, I think the first thing to recognize is that these were trials of older patients, right? The average age in these trials was around 77, 78 years old. Okay, that's almost a decade older than our AFib trials. So these are trials specifically of elderly individuals. And why is that important? No big net difference, as Paulus says, around bleeding, but we need to explore that further in terms of the very elderly, right? Remember, the one drug has an age-based dose reduction criteria, the other drug does not. And so, we need to tease that out and understand it. But, when we're looking at rates of bleeding, keep in mind, this is an elderly population. We drilled into this in the Averroes study, a nice analysis looking at age-specific bleeding rates. And, we talk a lot about how much bleeding there was. It's really in these device-detected trials, it's really the amount of bleeding relative to stroke. But the actual number of bleeding, based on Aristotle and Averroes and clinical AFib, if you want to compare apples to apples with 77-year-old people in those trials, the rate of bleeding in these device-detected trials is actually a lot lower. It's about 50% of what we expected based on the age analysis from Averroes. And there's many reasons. I think we're better at prescribing the drugs. Obviously, Averroes and Aristotle were very early days with DOACs. There's a lot less open label aspirin use. So only about 8%, 7% of people on Artesia took open label aspirin at the end of the trial. That's down from about 65% of people taking at the beginning. We know that this doubles the rate of major bleeding. So I think that all has to be unpacked. That's more studies to come. We've got a brilliant pooled meta-analysis coming with the two groups where we can tease that out in greater detail. But, the truth is the bleeding rates are lower than we'd expected based on the age of this population. So.
All right. Well, thank you for that information. I could talk about this for the next hour. There's so much I wanted to talk about. I wanted to dig more into burden. I wanted to dig more into patient wearables. I wanted to dig into a bunch of stuff. I want to really thank, Jeff and Paulus for taking the time to join us. These two are studs in the field, doing great work, some of the most important cardiology work, along with Renato, who is again unable to join us. I want to also thank my co-moderator, Naomi. This has been a great discussion. Thank you guys so much. Next slide.
Thank you.
Also, would remind you all to think about becoming an Anticoagulation Center of Excellence. Check out the website for more information on becoming a Center of Excellence, utilizing the resource center that we have there as well. And don't forget to join us in DC. We're looking forward to it, getting together again in DC, April 3rd through 5th, the Anticoagulation Forum 18th National Conference. 3 days of jam-packed sessions, lots of experts, lots of CE credit, a bunch of abstracts. We're going to have a blast. Always a good time. Thank you again to our panelists and to my co-moderator. It's been an excellent discussion. I look forward to chatting with you folks again. Thank you, everybody.
Bye-bye.
Thank you. Bye-bye. Have a good day or good evening.